Well, let me start by thanking you, Dr. Hill, for taking the time to present this topic. It's a topic of huge interest for all of us. And I want to just tell the audience that who you are. Obviously, we know you're a professor of medicine at Tufts University School of Medicine, and you're the chief of pulmonary critical care and sleep at Tufts Medical Center. And today you're going to talk about long-term NIV for COPD in 2023. And I'm really eager to hear what you have to say. And I've already got my questions lined up. So thank you very much. Again, appreciate your time, and please take it away.
Thank you, Steve. My pleasure. So, hello, everyone out there, and I appreciate your dialing in for the call. And this is a topic, long-term non-invasive ventilation for COPD, that has a bit of interest to me for a number of decades. And it continues to be a vexing topic. These are my disclosures, and I'm going to start out with a little bit of historical perspective. I'm going to spend some time talking about the current evidence that have given rise to the guidelines and also controversies. And the last is actually the possible role for high flow nasal cannula. So there's been interest in resting the respiratory muscles using non-invasive devices for in excess of 50 years. And during the 1980s, Norma Braun and Bill Marino published an abstract in Chest in 1984 that stimulated my interest. I had become interested in non-invasive approaches to ventilation. And they showed that in a cohort of patients with severe COPD treated with a negative pressure jacket ventilator, poncho wrap, as some people have called it, that I'm showing here, that using this over a period of weeks led to an improvement in inspiratory muscle strength, and they thought that this would be a good thing for patients with severe COPD who have mechanically disadvantaged respiratory muscle function. And it led Joe Zebrak, one of my former fellows, and me to do a small study, using these types of ventilators in a controlled fashion in an article that was published in 1988. And that work was followed up by work by Shapiro in Canada and Peter Macklem's group in Montreal on a larger cohort of patients. But both of us showed no improvement in respiratory muscle function compared to controls, and that COPD patients really disliked these ventilators. So we moved on, and so did the theory about how non-invasive ventilation might help, not so much by resting the respiratory muscles and strengthening them, but perhaps by improving sleep quality or decreasing hospitalizations. And by that time, I was very involved in positive pressure non-invasive ventilation, and had moved to Rhode Island Hospital at the time, and working with people like Dick Millman there. We did another controlled study, and the rationale here was that people with COPD have poor sleep quality, as was shown by Fleetum earlier during the 80s, and that this positive pressure approach might be a good way to improve the sleep, reduce respiratory events and desaturations, improve total time and REM sleep and so forth, leading to better functioning. And we published an article in what was then the American Review of Respiratory Disease, soon to become the Blue Journal, American Journal of Respiratory Critical Care Medicine. And it was the first study actually that used the BiPAP device. We had gotten permission to use the device from Jerry McGinnis, the founder of Respironics, and that was the device we used, but we showed no improvement. But several years later, Meacham Jones from the UK, with Visha Vejaha, who's former editor of the Blue Journal, they did a small study, and it was similar to the study that I did in Rhode Island, which was a randomized controlled study, but it was a crossover. And so patients randomly were allocated to use standard approach to supporting these COPD patients or non-invasive positive pressure ventilation for 3-month periods of each. And on the right here, David Strumpf was the first author. We had a total of 19 patients, obviously a small study, but a crossover. And we didn't show any significant differences other than the neuropsychiatric testing was significantly better, but we had a lot of dropouts. And then several years later, Meacham Jones did a very similar study, crossover 3 months each period, but they showed that there was a significant drop in PCO2, that sleep time lengthened, that not only was neuropsych better, but quality of life was better. But what was interesting about this was they started out with considerably more hypercapnic patients than we did, 56 as a mean versus 46 in our study. And also, their patients were less obstructed, their FEV1s were higher, and they had a little bit more frequent sleep events at night with hypopneas averaging 10, where we had done sleep studies and excluded anybody with AHI indices greater than 5. So this had a lot to do with the guidelines that were set up by CMS subsequently. And at that time, in the late 90s, there had been a rapid upsweep in the use of non-invasive ventilation for severe stable COPD based on a few of the earlier, mostly uncontrolled articles, and also the push that certain respiratory care companies were giving to primary care physicians who were prescribing oxygen, suggesting that patients would do better if they were added on with non-invasive ventilation. And so CMS, well, actually at the time it was Healthcare Financing Agency, HCFA, but in any case, they were concerned about the added expenditures and they wanted more guideline imposition, partly to try to curb this upsweep and to just direct it at people who are more likely to benefit. And the thing that came out of the contrast I just showed you between the Strumpf and the Meacham-Jones studies was to use a PCO2 in the low 50s. They agreed that 52 or above would likely capture the patients who are more likely to respond. But they also added, and this is something that actually came out of an ACCP, National Association of Medical Directors of Respiratory Care meeting that was convened to help provide guidance to CMS. This idea that not only did we need the hypercapnia, but we should show some evidence of desaturation at night. It's agreed that it would be 5 cumulative minutes. That would be indicative of hypercapnia, that the desaturations would reflect nocturnal hypercapnia. They also wanted that OSA be excluded on clinical grounds. They didn't require in-lab polysomnograms. And they also required that people start with the S mode, which was, the code was EO470, meaning that the patients would not have a backup rate for the first 2 months. And if they weren't doing well after 2 months, then they could add a backup rate. And this did a really good job of curbing the use of non-invasive ventilation for COPD, because it was very difficult to meet the 5 cumulative minutes requirement. When you think about it, it doesn't actually make any sense. There's no evidence base for it. And Jerry Kreiner has a small series of patients showing that even with rather severe hypercapnia, as long as you have some oxygen on board, you generally aren't going to see desaturations, as anybody who knows anything about gas exchange would not be surprised. The category, this was the category that they were talking about with these guidelines, was what they called RADs, or respiratory assistive devices, and they specifically are talking about CPAP or BiPAP type devices that don't have battery backup or relatively unsophisticated ventilators. And so they were able to reduce the use of them. Ventilators were defined as devices that could not only provide pressure support as the BiPAP type ventilators did, but also volume ventilation. And they were indicated primarily for respiratory failure. They were not being used a whole lot for COPD at that time. Now, a fair amount of additional work was done. I'm not going to spend any time reviewing it in detail, but I do want to just highlight one bit of evidence arising from a group in Germany led by Windisch, initially in Freiburg, Germany. And they developed the concept that one of the prior problems in showing benefit with non-invasive ventilation of COPD was that the pressures used were too low, and they were not capturing ventilation at night. They weren't lowering CO2 enough. At least this was their theory. And they were using pressures, inspiratory pressures of up to 40 millimeters, centimeters of water in the inspiratory pressure. And they did a study that was published in Thorax in 2009, illustrating the physiologic responses to this approach. They had 17 patients, all had severe COPD, average FEV 1.79 is shown here, hypercapnic, average PCO2 50, and they put them on a pressure support mode with the average peak pressure, inspiratory pressure, 29, obviously much higher than had been used in the past. The expiratory pressure remained low at 4. And they compared that to a period of time in the same patients, crossover trial, where the pressures were 15/5 for a period of 6 weeks. And 15/5 is closer to what people had been using in the past. And what they showed was that there was no difference in daytime PCO2, no change in FEV1 quality of life or inspiratory strength or 6-minute walk distance. But what they did show, as demonstrated in this diagram, is that while they were in period 1, which means the high intensity, as shown in the red arrow on the left, they were able to bring PCO2s nocturnally. This is using a transcutaneous CO2 device, down into the upper 40s, whereas the group getting the, quote, lower pressure did not significantly reduce its CO2s. And then when they crossed it over, so that the group starting out with the low pressures was put on high, here on the red arrow on the right, their pressures dropped down in the high 40s, and the ones getting the lower pressure rose back up towards 60. So a clear demonstration that nocturnal hypocapnia, or rather hypercapnia, is ameliorated by using these higher pressures quite effectively. And they control ventilation. They call it high intensity non-invasive ventilation. Around shortly thereafter, based on all the
Nick, did they measure volumes at all? Do they have any estimate of what it did to tidal volumes at night? They didn't use inductance or anything to try and get an estimate of volume.
They didn't use inductance, no. But that, certainly a very relevant question. So in 2013, the Cochrane group had a systematic analysis of the prior literature and concluded that at that time, nocturnal non-invasive positive pressure ventilation at home for 3 or 12 months in hypercapnic patients with COPD had no clinically or statistically significant effect on gas exchange, exercise tolerance, quality of life, lung function, respiratory muscle strength, or sleep efficiency, and should be used only in the context of a clinical trial. So, pretty damning statement on the evidence supporting the use of non-invasive ventilation for severe stable COPD at that time. But partly influenced by the work of Vindish and that high-intensity approach, that same German group and others in Germany, multi-center trial, did a study that's probably the most highly cited study and has been the most influential study in what's been happening subsequently. They enrolled patients who were hypercapnic. PCO2 had to be greater than 50, stable, defined by no exacerbations for at least 4 weeks. Nobody with severe obesity, no comorbidities that, virtually everybody with COPD has some comorbidity, but I guess they meant no significant comorbidities. And on average, they used an inspiratory pressure 22, lower than that 29, but still considerably higher than 15, low PEEP. And then one of the things about their high intensity is they use a backup rate they think is sufficient to control ventilation. And the total use was 5.9 hours per 24-hour cycle, most of them at night. And what they showed in a group of almost 200 patients randomized to either non-invasive ventilation or long-term oxygen therapy was that and by the way, the average FEV1 percent was in the stage 4 range, upper 20s, and the average baseline PCO2 was around 58. They showed after a year of treatment that there was a significant drop in PCO2. This is daytime PCO2 of 7.4 millimeters of mercury. And also compared to long-term oxygen therapy, it was only a drop in 2. So that was significantly different, although it does show that the patient still had significant hypercapnia, and the NIV group during daytime remained slightly above 50 millimeters of mercury. They saw a 2% increase in FE1% in the NIV group and a drop of 0.8% in the LTAT group, although it was statistically significant. One could question the clinical significance of a change like that. And likewise, the 6-minute walk distance increased by 7.6%. That was not quite significant. And the St. George's Respiratory Questionnaire dropped significantly, the minimally clinically important difference being 5 for that. But the thing that was most striking about this study was this dramatic drop in mortality from 33% in the control group down to 12%. And it looks like the effect occurred fairly early on, and the differences widened during the subsequent year. And this is why this study has been so influential. It raises a number of questions, and like any study, it has some limitations. But does this mean that NIV really is for stage 4 patients? It doesn't really tell us much about stage 3. What is an adequate pressure? They use 22. They had been advocating for higher pressures previously. And what is a sufficient backup rate? How important is that? They had no controls for any of these things, so they really can't draw any conclusions about mechanistically what exactly was responsible for the improvement in the mortality. Among the limitations, it was unblinded, very hard to blind these studies, of course. They had no compliance data. They had no sleep data. And also, one of the important things that I noticed in the methods, although nobody else seems to have commented, is that they prohibited use of non-invasive ventilation if these patients got hospitalized, unless there was an increase in PCO2 of more than 74 millimeters of mercury. And that was applied to the group that was not using NIV, but if they were using NIV, then this prescription didn't apply. And this might have something to do with the difference in mortality, that it was really what happened during acute hospitalizations. They also followed up patients by protocol every 3 months in the hospital, so the hospitalization data really wasn't worth much. The second most important study that came out a few years later, that the cone line, was 2014. Then in 2017, Murphy out of Nick Hart's group in the UK came out with the HOT HMV trial, which is home oxygen therapy versus home mechanical ventilation. Actually, the combination of home mechanical ventilation and home oxygen therapy in patients with severe COPD to reduce hospitalization and mortality. NIV was started 2 to 4 weeks after an acute exacerbation, generally after the patient had been sent home, as long as the PCO2 remained above 50. There were 116 patients, average age of 67, FEV1 very severe, 22%, BMI pretty low, especially for a COPD group in a Western country, PCO2 pretty severely elevated, 59, and also not a great PO2. They were placed on bi-level type devices, and IPAP 24, actually higher than the study by cone line. Backup rate a little bit lower than cone line, 14. Average use 4.7 hours per night early on in the study, and then 7.6 hours on average later on. And they found that in roughly 60 patients who were left for analysis in the HIV, HMV plus HOT group, there was a significant drop from baseline in PCO2. These are sequential PCO2s over the study done during the daytime. But the drop in both groups was comparable, as you can see, and not statistically different. The SGRQ was significantly better in the HOT HMV group, lower for an SGRQ, as I'm sure most of you know, is better, but it didn't reach the minimally clinical important difference of 5. Then the 12-month mortality was not different between the two. Exacerbations per year was lower, and the time to hospitalization or death, this a combined endpoint, obviously driven by hospitalization, was lengthened in the HOT HMV group compared to the oxygen therapy alone. This is the Kaplan-Meier for admission-free survival, and you can see, considerable splaying in people in the HOT HMV group. So they concluded that the HMV was prolonging admission-free hospitalizations. There were some obvious strengths, randomized trial, but the limitations included 18 crossovers from the HOT group to the HOT HMV group. And so that probably made it difficult to see significant differences in secondary outcomes, because if there was a favorable effect on survival of having HMV, then patients crossing over from HOT to HMV would benefit from that, and you're less likely to see a difference. There was significant number of dropouts, so the number of patients left in the study for analysis was much smaller than those who entered the study, and obstructive sleep apnea was not systematically evaluated, and again, it was unblinded. Now, one study that people don't talk about, which came out the same year as the cone line study did, was the Stroop study. Like the hot HMV study, this was a study of people who were enrolled after discharge for an acute exacerbation, but instead of waiting 2 to 4 weeks, they didn't wait. They started patients pretty much right either during or right after the hospitalization. The patients had to have hypercapnia, and the overall average was 58.5. So very similar to the baselines in these other studies. They had a couple hundred patients similar to the cone line study, but they had a lot of dropouts. They ended up with 54 completers in each group, almost half of what they started out with. And there were a number of deaths in each group. One of the interesting things about this study was that it was completely negative. The number of readmissions in the first year was about 2/3 identical in each group of people treated with NIV versus long-term oxygen therapy. Nothing with regard to quality of life, daytime PCO2. But the chart I'm showing here, the figure is for the drop in CO2 from the start of the study to the finish. And what you can see is that the drop in PCO2, for all practical purpose, was about the same, although actually they did get a statistically significant difference. Clearly, it's not a clinically significant difference. And one of the things that people have said about this study is the reason it was negative, and here are the survival curves, which are virtually superimposable, is that they started right away, and they should have waited 2 to 4 weeks like Murphy did to make sure that these are persistently hypercapnic patients. They had the same strengths as the others, but they used slightly lower pressures. I don't think it's low enough to explain the difference. This is inspiratory pressure 21. They weren't as obstructed, 33% for FEV1. Lower backup rate, 12 compared to 14 and 16 in the Murphy and cone line studies, respectively. And maybe they just weren't severe enough chronic CO2 retainers. And a lot of dropouts made it difficult to have the statistical power that they needed. So when you take a close look at the data in these individual studies, I think, there are a lot of questions it raises. But of course, people are going to do meta-analyses. So there was a meta-analysis published by Wilson, JAMA 2020. The cone line study it was responsible for about 10% of the effect, but they concluded that for patients on a BiPAP type ventilator, there was a significant reduction in 1-year mortality from 28% to 22%. Hospital admissions, a hazard ratio of 0.5, so a cut in half compared to controls. In this lumped sample, they could not find a significant effect on health-rated quality of life. And for those fewer studies that were done on using mechanical ventilators, the volume limited ventilators, they could just find significance for decreased hospital admissions, not for mortality or quality of life. And this was very similar to an ARC study that came out in 2018. But once you have the findings from meta-analyses, somebody's got to do a big data analysis. So Fraser has published 2 articles using Medicare claims data. The first one identified 36,000 patients with Medicare claims using with COPD serving as the controls, and identified 410 patients using NIV at home for their COPD. and found a 38.3% reduction in mortality over a year's use. And then did a second study using 500,000 claims, identified 7,000 hypercapnic COPD patients with chronic respiratory failure using NIV at home, and the risk of death compared to controls was reduced by 43% when NIV was started the first week following diagnosis, 31% 18 to 15 days following diagnosis, and 16% for those subsequently. So it suggests that using these large numbers, there is a mortality signal, and also it's interesting that the sooner that NIV gets started, and this would relate to this idea that we're waiting 2 to 4 weeks after an acute care hospitalization is desirable. Here, the longer you wait, the worse you do. And so there are a lot of problems with big data analyses. You know, you get a 35,000 foot view, but you don't get too many details. But I think it does raise some questions about exactly what timing you should use when you start NIV. So we've had a number of guidelines published in the last few years. Both the ERS and the ATS suggest use of NIV in stable hypercapnic COPD, and also after an acute episode, at least as far as the ERS is concerned. The ATS buys into this idea of waiting 2 to 4 weeks after an acute episode before starting, and they recommend targeting a normalized PCO2, although you might have noticed in the studies I went over that nobody actually normalized the PCO2. PCO2 came down the most in both the controls and the treated group in that study that showed no differences by Strook out of the Netherlands. And then the GOLD people have been somewhat less enthusiastic. They say that NIV may improve hospitalization-free survival in selected patients after recent hospitalization, especially if they have the PCO2 52 or greater, but says this is undetermined, and they don't actually suggest or make any recommendation about it. So, you know, the indications for ventilators, the EO466, and this is CMS lingo I'm using, so they're distinguishing this from RADS, is that it's usable for obstructive lung disease, restrictive thoracic disease, other hypoventilation syndromes, as long as they have documented respiratory failure. And they have made it easier to prescribe these things. And you know, we all know the commercial names, but they're, you know, the Trilogy line of ventilators, the Astral, a number of others being manufactured by others, Bries with the Vivo, and a number of others. But these are easier to prescribe for physicians for severe COPD because of the barriers that CMS has placed with its requirement for nocturnal oximetry and just an S mode. And so they have driven the market treating COPD with NIV toward these ventilators, which are much more expensive to administer. As most of you probably know, CMS will, or Medicare will reimburse up to 13 months for a BiPAP RAD type device. It's capped rental, whereas the ventilators have no capped rental, and they generally reimburse about twice as much indefinitely. So if you're running a respiratory care company, you're obviously incentivized to have these kinds of the ventilators prescribed. And there's been a large increase in the number of prescriptions that has been alarming to CMS, probably about a 10-fold over the decade 2010 to 2020. And as a consequence, we put together a group, Peter Gay, led this initially with NAMDARC, which was subsequently absorbed into the ACCP. But there was a group of experts describing itself as the optimal non-invasive ventilation Medicare access promotion technical access panel. But it met a number of times late in 2020, put together a document published in Chest in 2021, looking at not only COPD, but also restrictive thoracic diseases, including neuromuscular disease, other hypoventilatory disorders, and trying to get some rational guidelines. And for COPD, we strongly recommended eliminating the need for nocturnal oximetry, eliminating the need to start with the S mode, because all these studies have used backup rates. There's really no evidence to say that starting with an S mode is an effective thing to do, and then extend the time for reevaluation from 2 to 3 months. We submitted a request for a national coverage determination to CMS and have been told by CMS that they will consider suggestions for COPD, not the other things. And they gave us no timeline. So Lord only knows where that's going to go. And at the moment, the reimbursement situation is the same as it was 10 years ago. One thing we did come up with was this algorithm for how we think COPD patients should be treated. If they meet the usual criteria of greater than 52, we get rid of the nocturnal oximetry requirement. So the other requirement is just that they don't have sleep apnea on clinical grounds. If they meet these criteria, then they go on bi-level device. If they're adherent and they're doing well after their evaluation, they stay on the BiPAP. If they have failed to meet the goals after 3 months or have these other requirements that are listed in our algorithm, then that's a justification for going for a ventilator. Now, I'm just going to make a few comments about high flow, but there are several articles out there that have shown that using high flow in the home, 4 to 7 hours, 20, 30, 40 liters a minute. This is an article by Stogard out of Denmark that showed doing this on a daily basis in a group of patients with severe COPD significantly reduced the occurrence of exacerbations over the next year by 37%, trend towards fewer hospitalizations, significantly reduced MMRC dyspnea score, preserved quality of life and 6-minute walk distance. There was a more recent study published last year in the Blue Journal, roughly the same size study. In this study, patients were placed on high flow, 30, 40 liters per minute. They used it for an average of 7 hours per night. The occurrence of moderate to severe exacerbations over the next year was 1 in the high flow group and 2.5 per year in the controls. Median time to first exacerbation was lengthened. In fact, in the treatment group, it didn't actually reach median at the year marker, and it improved health-related quality of life, some improvements in FEV1 and O2 sat, but questionable clinical significance, and they concluded that it is, quote, a reasonable therapeutic option. And then Jerry Kreiner, who's had a big interest in this, published a pilot study, 28 patients, in the Journal of the COPD Foundation, 21, but using a very similar approach. There were improvements in feelings of breathlessness, wheezing, sputum volume, color and consistency, trends for 6-minute walk distance, quality of life. And so he is putting together a study. We're going to participate in it. It has started enrollment, but has off to a fairly slow start to reach 642 patients at this point. But he's taking people with severe COPD in group D or more recently E now that the GOLD has changed its categories in the last iteration. A recent exacerbation, And his major outcome variable will be time to exacerbation or death. So to conclude here, a long-time goal that has generated a lot of controversy over decades is the application of NIV for severe stable COPD in the home. And recent larger randomized trials have demonstrated improved mortality, health-related quality of life, and decreased hospital admissions. Quality of evidence is still not high, and some conflicting recommendations between societies remain, including when to start and whether to normalize PCO2, as I've shown. Higher inspiratory pressure range, low 20s, does seem to be important in these studies. I think it is the case that we didn't have as much success because we weren't ventilating with high enough pressures. Ideal candidates have hypercapnia and generally a history of exacerbations. The Medicare guidelines for these devices do not align well with patient needs, and attempts to improve them are underway, although it's unclear what CMS is going to do with it. And finally, high flow may be an alternative that is better tolerated and will reduce hospital admissions as well. So I will stop there, and I would love to hear people's thoughts on this. Thank you.
Thank you, Dr. Hill. Great presentation. Anyone have comments, questions?
So, Jerry, one question that always comes up, I remember when I was early on in the days of sleep apnea when we were studying, was patient compliance and how much noise that introduces into a study where the variability among the patients is so great. How do you think, do any of these studies really have reasonable measures of patient compliance in addition to just reporting from the self-reporting?
They do. And the technology of the ventilators and bi-level devices that we have now allows us to track compliance pretty well, even in patients not in studies. We can download the number of hours per 24, and we can look at the pressure changes over time and number of breaths triggered. And, you get a lot of information about what patients are doing with their ventilators and how the ventilators are doing with them. In the cone length study, I mentioned that they didn't do this and they didn't have any compliance data, but in the stroke study that was done around the same time, they followed compliance very closely. And so they were able to track hours accurately. And the more recent studies do this. And it is possible to get your average patient up over 4 to 5 hours, which seems to be important to get any kind of effect. But this is obviously an extremely important part of it. And the study I showed most recently, the high flow study from Japan, they took patients who were stage 4, and they had low 50s in each group, and they didn't report any mortalities at all. And whereas these other studies out of Europe have shown generally in the range, somewhere in the 20% mortality after a year in the same kind of population. So, you wonder if people are complying too well or surviving too well about how they're ending up with that result.
Right.
Hi, Nick. Can I ask a question? Sorry.
Of course.
Yeah. My name is Ihab Dawood. I actually did my fellowship in Brown in Rhode Island. I'm not sure exactly, did you leave at that time or not, but we used to go to Mass for some conferences and stuff. So I only work in ICU. I know kind of like a little bit deviation from this exact topic, but what's your thought about now there's so many non-invasive ventilators, basically the dedicated ones for non-invasive versus like most of the new generation ventilators now have non-invasive. And that looks like the studies are conflicting, that at least they've been old. Now each ventilator has their own algorithm for leak compensation and stuff like that. Actually doing a international survey now about what clinicians would like to use in the ICU or in the hospital. What's your thought about those different ventilators versus non-invasive?
Well, you pointed out an issue that does need a little more attention. There are devices that have been designed specifically for use of non-invasive ventilation in the critical care area, and I have in mind, for example, the V60, which is the one we use at my place, and it's a progeny of the Vision ventilator in the Respironics line, and they have a lot of experience doing this. I think it's a very good machine, and it has an algorithm in it with a proprietary name, the AutoTrack, and it does, I think, a very good job of dealing with leaks and maintaining synchrony. It's not perfect, but most of the ventilator manufacturers, as you point out, the critical care ventilator manufacturers have an NIV mode. You press a button and it makes the ventilator more leak tolerant, makes it easy to use to ventilate in pressure support mode, but it can deliver volume or pressure control. It gives you a lot of choices over the mode. And you can do more with those kinds of ventilators with what you're delivering than generally you can with something like the V60, which has a lot of automatic features to it. There have been some studies looking at how these things perform compared to each other. They're generally obsolete by the time they get into print because advances come very rapidly. But there have been studies showing that some of these things are more apt to auto cycle than others, or they have problems with more problems with cycling under certain circumstances. So there are differences between them that might be important. But I think what you have to do as an individual clinician is get familiar with what you have. In my hospital, we have mainly Puritan Bennett 980s, which, if they're properly adjusted, I think they do a reasonably good job of providing ventilation to people with acute respiratory failure on non-invasive ventilation. But that would be my view of it.
Yeah, we're trying to do a study also to compare, because again, most of the ventilators now have like new algorithms, as you mentioned. Even the V60 is like V60 Plus. The Hamilton has one like auto sync. So there's, as you said before, like getting the right device to the right patient. I don't believe that they're all equal.
They're not.
Yeah.
Really not. Yeah, you may recall Bob Kazmarek. Many on the call undoubtedly do, and he unfortunately died a couple of years ago. But he did a number of these kinds of studies, and I worked with him on one of them that was related to mainly to non-invasive type ventilators. But our study was published, I think, in 2008, so it's completely irrelevant today because of the new ventilators that have come out. But we showed substantial differences between the different ventilators when you exposed them to a little leak or a lot of leak in terms of how they were able to synchronize and compensate for that. But it's a rapidly moving field, and people are coming out with new devices all the time. One of the things we're seeing is the addition of high flow now in a lot of these critical care ventilators. I know the 980 has introduced it. The V60 comes with it. They go up to 80 liters a minute. Once again, there's very little clinical data, but we generally have used just wall compressors and oxygen and a flow meter through a humidifier, and that's how we've been delivering the high flow. But
therapists call those pigs on a stick. Dr. Hatipolo, you had a question?
So, yeah.
Yes, I do. I'm Umar Hatipolo from Cleveland Clinic. Dr. Hill, good to see you again. And God, I have so many questions, but I'm going to ask you one that may encompass most of them. So as you know, all of these studies were done with patients being titrated in the hospital in Europe. Somehow they're still able to afford that. In the United States, this is probably not possible. Using the sleep lab is probably not possible either because of expense and how tight those spots are. So my question to you is, do you have a program for patients with COPD and chronic hypercapnic respiratory failure? And how are you circumventing this titration issue?
The issue being the inability to do this in the hospital.
Exactly. How do you titrate to high inspiratory pressures?
Yeah, you don't need to do this in the hospital. Some people do it in their office. Some people use durable medical equipment companies with therapists who are skilled at doing this. But it is a problem, and I don't have a large program that employs its own therapists who get skilled. I have to use different therapists from different DME companies. We do mechanical ventilation at home in a rather haphazard way in this country, compared to, say, France, where they've been, had a pretty well-run national program for a lot of years. But my approach has generally been to gradually increase the pressures as tolerated and monitor their responses, have them come in after the first couple of weeks, mainly to reinforce them. But I might start them on, I'm limited by what they can tolerate acutely, but often they may start out on pressures of 10/5, and then I gradually go up by increments of 2 centimeters water pressure most of the time over a period of weeks. And it might even be months before I get them up to where I want to. My target is in the low 20s, similar to these studies, not up to 40. I did visit Germany one time because I couldn't believe there were patients who were tolerating 40 centimeters water pressure. And they showed me about half a dozen patients who were tolerating pressures like that. And they were in the hospital, as you point out. But there was one gentleman who was in his middle 70s and had only been in there for a week. And he was obviously not happy with being subjected to these high pressures. And I asked him why he was doing it. And he said, because my doctor told me I must.
He was German, though.
Exactly. You're not going to find that here. So you have to be a little more gentle. But that's basically how I do it. And I do nocturnal oximetry on them. I'd love to do transcutaneous CO2s in the home, but they're virtually impossible to get because of the expense involved, and the durable medical equipment companies just can't afford to do them. Some of them do end-tidal CO2, which is cheaper for them, but it's not useful because with the leaks, you don't really get reliable data.
So we started titrating patients in the outpatient with transcutaneous CO2 monitoring because we didn't really have anything better to do to see where they would end up. The other problem we run into is once you increase the pressures to over 20 centimeters water, IPAP, you start getting these huge tidal volumes. They exceed 1 liter. So my second question to you is, if the issue is just imposing alveolar ventilation, why are we so stuck on high pressures? Why can't we go with a combination of respiratory rate and tidal volume, and the pressure that gets us to that value?
To get to what value?
To the goal transcutaneous CO2 or ABG PaCO2. What are your thoughts on that?
Well, I think the issue of what the target CO2 should be is wide open, because as I pointed out, none of these studies normalize PCO2, and yet the ATS guidelines say try to normalize PCO2. Nobody has done a study looking at what happens if you lower the PCO2 to 40 as opposed to 50 or even 55 or 60. And I don't believe that lowering it to 40 is necessary. But if you want to do that, then you are going to have to use high pressures and high volumes. These people, have bad COPD, so you're going to be limited on what rate you can crank it up to.
Absolutely.
So is it healthy to have a tidal volume that big in a patient with bolus emphysema? I have concerns about that. Of course, nobody talks about pneumothoraces. So there's more work to be done. You have pointed out some areas where partly how do you start people in the U.S. on these kinds of modes, or anywhere in the world really? What target CO2? What is the best mode to use? A lot of people like AVAPS AE for COPD patients, but the data are very flimsy on that, and none of these studies have used that. They've all used standard pressure support type modes, bi-level type modes.
Yeah.
So a lot of questions that have not been answered.
Yeah, absolutely. And I'm also struck by the fact that, you can't really put in the same bucket the patient with a PCO2 of 90 and PCO2 of 55 or 60. I mean, the alveolar ventilation that needs to be imposed on the patient with 90 to come down by 20% is much less of a increment than what you would need to do for someone to go from 60 to say 50. It's the simple, inverse curvilinear relationship between alveolar ventilation and PaCO2. So that part also bothers me when we say, high intensity ventilation is normalizing PaCO2. I just don't see it happening in many of the patients, actually.
I agree with you entirely. And it could be more dangerous to do it than to, accept higher PCO2. The studies that I've done, and this applies to neuromuscular disease as well, is that if you can control the nocturnal hypoventilation reasonably well, and by that I mean probably maintaining somewhere in the range of 50 and preventing it from shooting up at night, people sleep better, they function better. That may be, more reasonable target.
Yeah.
But there are a lot of people out there who are advocating for complete normalization.
Dr. Gentile or Jeff or Rob, you guys have been quiet. Any questions for Dr. Hill?
Yeah, I have one quick question just about the statistics. You reported a number of percent reductions in outcome variables, and I was wondering, are those relative or absolute reductions, or relative absolute risks? And when you're talking about something like a decreased mortality at 1 year, how much extra life are we talking about in terms of months?
Most of the percentages I was talking about were absolute. We'd have to go through and pick out the ones that are relative, but I can't think of any offhand, mainly absolute changes. And how these mortality statistics translate into longer life, I don't know. Actually, the only one that really showed a big effect on mortality was the cone line study, and there after a year, there was a 33% mortality in the standard oxygen group and a 12% mortality in the non-invasive ventilation group. And it's hard for me to imagine, if that's true, that it wouldn't translate into a longer life. That's clearly a very striking difference. But I pointed out that hidden in the methods of that study is this statement that they discourage use of NIV in patients who were in the oxygen group unless during acute hospitalizations, unless the PCO2 went over, to 75 or above. That's not standard practice. We start people on non-invasive ventilation for COPD if their PCO2s are much lower than that and their work of breathing is high. So they may have, kind of set the stage for a higher mortality in the during the acute hospitalizations in that group, and maybe that explains why their differences are so much greater than anybody else has gotten.
So, Nick, this is Mike. Once again, always a great time listening to you talk about this, and thanks for all the work you've done in this field. I remember when we used to call it TRIPAP in the hospital. We would call it TRIPAP because we would try it for a while, then we'd intubate the patient. But that was, I think, a lot of bias and certainly in the early days technology. But if you could advise, especially younger, I heard many people say they were doing their own studies. What are the unanswered questions in this field, right? I mean, what at the last, in your closing slide, you talked about high flow nasal cannula. So I'm curious about your thoughts on what are the unanswered questions now that you can look in the mirror and say, this is what we've done, this is what we've learned, because we got to make it easier for clinicians. That's the CMS part. We got to make it better for patients and easier for patients, or however you want to phrase that.
Well, I could go on for a long time on unanswered questions, but I think you're asking really what key questions might be out there.
Right.
When I look back on, the last 30 some years, we have come a long way. And the kinds of things that we do better, synchrony was a big problem with the initial BiPAP type devices. The original BiPAP would go on for 3 seconds in the face of a leak, and then it would stop due to the algorithm, and then almost immediately would kick up again because the leak would trigger the ventilator. So, it did a terrible job of synchronizing. The V60 with the AutoTrack is incredibly better, but it's not perfect. And we have a lot of people who still are having trouble with asynchronies during leak. The ventilators are not great at triggering or cycling in the face of a large leak, even though they're a lot better. So I think one part of it is, how do we get people to synchronize better? The interface has always been a big issue too, and we've come an incredibly long way there as well. The number of times I see a nasal ulcer, a bad nasal ulcer is, just a fraction of what I would see 20 or 30 years ago. So we've come a long way there, but we can do better. And, one of the limitations is living within cost constraints too, because, you can make a great mask for a lot of money, but if you want something that costs, 15 or 20 bucks, it's hard to use great materials. And then how do you select the best candidates? When is it that you intubate these patients? Who do you extubate onto non-invasive ventilation? What about using non-invasive ventilation and high flow in tandem? In the pandemic, we did that fairly often in patients who had been intubated for a few weeks and were severely deconditioned and had inspissated secretions. We'd kind of alternate going back and forth. We used the cough assist in some of these patients as well. So, there are a lot of ways of approaching these people, and we need to learn a lot more about how we can best do that. Secretion control has long been a big problem, and non-invasive ventilation alone does not do a great job of controlling secretions, and that may be a cause of failure not infrequently. So that's just a few random thoughts, but like I said, I could go on for a while.
All right, thanks.
Well, thank you.
One more question, can if you don't mind?
Absolutely.
All right. Again, in the hospital, in the ICU and stuff, you talked about the home, about the difference between high pressures and low pressures. How about in the acute care setting? I remember some studies in the past is like when pressure support goes above 15 or 20, and the patient's still in respiratory distress, they sometimes can have more dysynchrony. Sometimes it means more failure. So if I have a patient COPD exacerbation and on non-invasive, and I go like say above 20, and the patient's still in distress, I would say, okay, well, we should have intubated that patient. Should I go to 40 like in these people, or
Absolutely not.
yeah, well, that's what is.
Yeah, so we've done a lot of studies on this, and one of the studies we did, I think, was published in 2014 in COPD was we had done in-hospital surveys of what people were doing, and the average overall pressure of non-invasive ventilation using bi-level settings at that time was 12/5, with backup rate, lower than spontaneous, but usually is 14 or something like that. And it was mainly in COPD patients, some acute cardiogenic pulmonary edema, but those aren't very high pressures at all. And I think it's a reflection of what people were doing, but also that patients aren't going to tolerate pressures much higher than that acutely. And as you go cranking it up, you're going to run into more and more intolerance. There have been studies in the literature where people have started at 20 and then titrated down. I've generally started lower and titrated it up, trying to get people relaxed. And on average, you're going to need more pressure with hypoxemic respiratory failure. And those patients are more difficult to manage. Non-invasive ventilation does very well with COPD exacerbations on average, but the people with hypoxemic respiratory failure developing ARDS or with severe pneumonias are much harder to manage, and you have to be very cautious with those people because delayed intubation leads to catastrophe. We've known that for a long time. So if you're having to use pressures approaching 20 in a patient with hypoxemic respiratory failure who's very tachypnic and uncomfortable, I would intubate that patient. I think the dangers of prolonging non-invasive ventilation under those circumstances outweigh just going ahead and intubating.
Thank you.
Thank you, Professor Hill. I know we'll circle back, and I would love to have you join us to discuss high flow as well, and some of the challenges there and the application of that technique, that therapy to patients. So I appreciate your time. Thank you, everyone, for attending. And if there isn't any other questions, please have a good day, and thank you very much.
Thank you.
It's been my pleasure. Thanks for all the questions, and appreciate being invited to do this. Good night.
Thank you.
Good night.
Good night. Thanks, Nick.
You're welcome.